for food. So I'm Will Dodd. I'm one of the co-chairs of the Grand Rounds Committee. Today it's my pleasure to introduce Dr. Mary Kearns. Before I introduce her, though, if I could remind everybody to please call this number up here and type in the ID into your phone. That'll record CME, and it also records attendance for the Grand Rounds and helps us get food and recording equipment and make everything happen. So even if you're a resident, you may not need CME. If you wouldn't mind giving it a call and just logging in, we'd appreciate it. Also, I'd like to state that Dr. Kearns has no conflicts of interest today. So looking through Dr. Kearns' resume, I got to say I was totally impressed. She got her undergrad from Notre Dame and MD from Florida International down in Miami before joining us here for Pediatrics residency. She has several research publications, including a talk at the National Allergy Immunology Conference about angioedema. She has a publication on food allergies, also Niemann-Pick disease and stopping terminal resuscitation. She's also involved with the Bronchiolitis QI project, and not to my surprise, she's been Resident of the Month multiple times. I think anybody who's worked with her realizes how much she cares about her patients and how great of a job she does. And she's going to leave us soon and go be a general pediatrician in Florida near her family, and she enjoys spending time with us. So, Dr. Kearns.
All right, thank you, Dr. Dodd. So food allergy is a topic that I'm pretty passionate about. I like it a lot because my baby brother Anthony, who's now 16 years old, has several severe food allergies. He's the only person in my family, the first person to ever have a food allergy. So there was a steep learning curve for all of us, and my self-education and interest in that kind of drew me into medicine in the first place when I was younger. So today I wanted to talk about food allergies from IgE to empathy. I don't have any financial disclosures, and I won't be talking about any unapproved or investigative devices. So I wanted to start with objectives. Hopefully this presentation will help us understand the basics of food allergy diagnosis and management, understand the prevalence of food allergy in the United States, and recognize the psychosocial impact that food allergies can have on patients and their families. So I wanted to start off with some terminology. An adverse food reaction is kind of an umbrella term that includes food allergy and food intolerance. A food allergy is an adverse immune response, and a food intolerance is an adverse non-immune response. And food allergies are usually due to an immune response to a protein in foods. They can be either IgE mediated, where an IgE antibody develops against a protein, or non-IgE mediated, or somewhere in between. IgE-mediated food allergies are acute in onset and include oral allergy syndrome, which probably most of us are familiar with. It's an allergic reaction that manifests with symptoms in the mouth, including itching, burning sensation, and it's usually from uncooked fruits, nuts, and vegetables, and it rarely progresses to a severe allergic reaction or anaphylaxis. Urticaria, which is hives, and anaphylaxis, which is the most severe form of an allergic reaction, and pretty much what I'll be focusing on today. And I mentioned the other types of food allergies. The non-IgE mediated food allergies have a more delayed onset of symptoms. The symptoms are usually GI related, including symptoms of malabsorption like steatorrhea. And then some examples are like FPIES, food protein-induced enterocolitis syndrome, where you have symptoms of vomiting, diarrhea, in severe cases, dehydration, acidosis, dermatitis, herpetiformis, intensely pruritic, papulovesicular rash, and then Heiner's syndrome, which is food-induced pulmonary hemosiderosis. And then the mixed food allergies include celiac, eosinophilic esophagitis, and atopic dermatitis. So for the purposes of this presentation, when I say food allergy, I'm going to mean IgE-mediated food allergies. So this is a chart that I found from the CDC that shows the prevalence of food allergies in children in the year 2007. And you can see that there's like a total prevalence of about 4%. Current estimates are that between 4 and 8% of children in the United States have been diagnosed with food allergy, which is 1 in 13 kids and about 6 million kids nationwide. And then an estimated 30.4% of children with food allergy are allergic to multiple allergens. So food allergies usually develop within the first 2 years of life, and as you can see, the prevalence of food allergies in kids that are less than 5 years old is higher. It's about 5%, which is actually statistically significant. And we can kind of discuss why this is a little bit later. You can also see it broken down in different demographics. And then another chart that I got from the CDC that shows kind of the nice steep slope of how much and how quickly the prevalence of food allergies in children increased from the decade of 1997 to 2007. So the prevalence of food allergies as a whole in the last decade has increased by 18%. But the increase, according to FAIR, which is the Food Allergy Research and Education Organization, between 1997 and 2008, the prevalence of like peanut and tree nut allergy more than tripled in the United States in American children. So, and then I just have another chart from the CDC, which I think gives a pretty good visual for like the increasing problem of food allergies, not just for kids at home, but also in the hospital setting. So this shows the average number of hospital discharges per year among children under the age of 18 who are hospitalized with a diagnosis relating to food allergy. And you can see that between like the last one there in 2004 to 2008 and 6, that the number of discharges is more than triple what it was in 1998 to 2000. So about 40% of children with food allergies will have a severe reaction. Only a small percentage of those will require management in the emergency department or a hospitalization. So according to the National Electronic Injury Surveillance System in the United States, in the year 2007, there were approximately 30,000 cases of food-related anaphylaxis seen in the ED and about 150 deaths. So that's a small percentage of fatalities for severe food reaction, which kind of speaks to the efficacy of the appropriate management of anaphylaxis. So there are several risk factors for developing food allergy. I try to pull out some of the more important ones. Family history of food allergies. Obviously, a history of previous food allergy makes you predisposed to developing other allergies to other foods. And then a history of atopy, like asthma, eczema, or allergic rhinitis, is also a risk factor for developing food allergies. Children with food allergies are actually 2 to 4 times as likely as the general population to develop atopic conditions. And food allergic children with asthma are actually thought to be at increased risk for severe reactions to anaphylaxis and kind of subsequently death because they have the addition of the asthma and the respiratory symptoms. So who is to blame for food allergies? Well, not all of them, but these are the big 8, which are responsible for up to 90% of food allergies. We should all be pretty familiar with this list now. It's cow's milk, hen's egg, wheat, soy, peanut, tree nuts, fish, and shellfish. And then up to 26% of children with food allergies will outgrow them. And the median age of tolerance development is about 5.5 years. There are some studies, there's some evidence now that looks and feels that food allergies are persisting longer than 5 years, so maybe that median will increase, or maybe we'll be seeing fewer children outgrow allergies. But this outgrowing of the allergies accounts for why the prevalence of food allergies in younger kids is so much higher, statistically significantly so, than older children. And then just the commonly outgrown allergies, so what we see in children that they generally outgrow: milk, egg, soy, and wheat. And then the ones that persist into adulthood that we're all familiar with: peanuts, tree nuts, fish, and shellfish. So IgE-mediated food allergy is characterized by an acute onset of symptoms, usually within minutes, but actually up to 2 hours of ingesting an allergen, and it affects many organ systems. So it's kind of a constellation of symptoms. You can have one of these, or you can have several. So skin symptoms include hives, which could be localized, which would be more mild or widespread. In the mouth and oropharynx, you can get dysphagia, hoarseness, angioedema of the lips and tongue. Cardiovascular symptoms like hypotension, weak pulses, and dizziness. Obviously, hypotension and weak pulses being of the more severe variety of symptoms. And then respiratory symptoms including dyspnea, wheezing, cough, GI, nausea or discomfort, vomiting, diarrhea. And then something that I kind of learned that is considered symptoms of food allergy are the psychological impact. So the sense of impending doom that can often accompany an anaphylactic or severe allergic reaction, anxiety, and confusion. So anaphylaxis is the most severe form of a food allergy. It can lead to shock, anaphylactic shock, and by definition it involves 2 or more organ systems. So how do we diagnose food allergies? This is kind of a hot button topic. Well, history is the most important diagnostic tool that we have. It helps us determine the pretest probability of any testing that we do down the line. Of other testing modalities, we have the gold standard, which is oral food challenges, which involves a patient kind of ingesting the allergen at increasing doses and being monitored for any kind of reaction. In a research setting, this would be double-blinded and placebo-controlled, ideally. But as you can imagine, that's not really realistic in the clinical setting, so usually they're unmasked or single-blinded food challenges in the clinic. These should only be performed by an allergist who would, in a medical setting, so that there's a way to treat symptoms if they arise. There is a risk anytime you're going to ingest an allergen of a severe allergic reaction. And then the other tests that I'll talk about are skin prick testing and serum IgE levels. So skin prick testing involves a small pinprick to break the skin and then introduction of an allergen. It does have a fairly high, like 50 to 60% false positive rate. And then of note, very important, that prior to performing the skin prick testing, patients who are on medications that could interfere with the test need to hold those medications. So that would be antihistamines, which includes both H1 and H2 blockers, and then also tricyclic antidepressants, because those can also be histamine antagonists. And then as with oral food challenges, skin prick testing should be performed by a specialist who's qualified to interpret the results, particularly due to the high false positive rate. And then I have kind of just a little brief relevant Anthony story. When he had his skin prick testing done, he tested positive to something like 55 of the 90 or so allergens that were tested, including some false positives like lettuce, black pepper, corn, vanilla, cinnamon that he had never reacted to in the past. And then when he went to camp, they needed food allergy documentation, so my mom sent the results, the full results with the highlighted true allergies. But the camp couldn't ignore a positive result, so they had to avoid everything that was there. And he was served turkey sandwiches for breakfast, lunch, and dinner for 3 weeks straight. And he almost got to eat grilled chicken once, but it had black pepper on it, so no dice. So that's the danger of having non-specialists try to interpret skin prick test results. Serum IgE testing measures the amount of specific IgE antibodies that are present in the serum. This only detects sensitization to an allergen. So because of this, it has about a similar false positive profile to skin prick testing. And a positive test won't necessarily indicate an allergy. So it's highly discouraged that general practitioners don't perform broad food IgE panels like some have in the past without some sort of really strong indication or rationale that is derived from a thorough history. And so it's usually advised that we leave serum IgE testing to the specialists because they're best equipped to interpret the results. And then it's worth noting that neither skin prick testing nor IgE testing are sufficient to make a diagnosis of food allergy on their own. But if they're accompanied by like a very strong history, then they can confirm the diagnosis, and then you don't need to do the oral food challenge to confirm. So management of food allergies it's two-pronged, I guess. There's two major components. There's avoidance and treatment of symptoms. Avoidance of allergens in the home is pretty important, especially in the first few years of life. It's achieved through strict label reading and avoiding cross-contamination. The FDA requires that the big 8 allergens that I had mentioned before are stated in plain English on any ingredient label. And then some packages will also include a may contain statement. And these statements are voluntary, they're not regulated by the FDA. As far as avoiding cross-contamination, they have to be careful not to share utensils. If there is an allergen that is makes contact with a surface or a dish, it needs to be cleaned adequately. Also worth noting, and something that we should remind our patients, you read a label once, that's not enough. There can be changes to the ingredient list, changes to the recipe, so they need to be reading and rereading those labels every time they pick up that package, whether it's to buy it or to eat it, just to make sure. And then avoidance in schools has been fairly trendy in recent years. Many schools now, I hear a lot of patients who aren't allowed to bring peanut butter and jelly sandwiches to school. So schools are limiting what kids can bring in with them, or they will try to limit exposure by separating out the kids with food allergies to an allergy-free table at lunchtime. From the evidence that I had kind of looked at, interestingly, maybe counterintuitive, this hasn't really decreased the amount of reactions that we have seen in schools, but it's interesting to see kind of where this is heading. In 2008, the ADA expanded to cover episodic disabilities, so like food allergies or epilepsy. So that then food allergies became covered by Section 504 of the Rehabilitation Act of 1973, which entitles students to a 504 plan to help minimize the negative impact that any sort of disability could have on their education. So now kids with severe food allergies are entitled to these plans. Other interventions are medical alert bracelets, and education and awareness is a big one that we perhaps don't realize. So it seems kind of impossible, or it seemed to me impossible that anyone is unaware of food allergies, especially because it's all over the place in the news and the media. But there are still a lot of misconceptions that are out there about food allergies and their severity. And so I think education and advocacy campaigns can be crucial factors in dispelling the misconceptions. FAIR, Food Allergy Research and Education, it's the leading national organization dedicated to food allergy. And it's a great resource for patients and their families. It has resources there on their website from diagnosis on to different transitions in life. And then I wanted to share this video from FAIR, which I think does a good job of showing misrepresentation of food allergy in the media. If it'll work, we can try.
Food allergy is unloved, it's not understood.
Excuse me, my friend is having an allergic reaction to peanuts.
No, he's
not.
Unfortunately, there are many misrepresentations in the media of what food allergy really is and how severe it really can be.
Kids are still being bullied about food allergies, and they are still being treated like they're not serious. And I think the media plays into that.
Next up, from the Minnesota Vikings. He was voted most likely to have to warn his team again about his intense peanut allergy. Guys, I'm serious.
I've seen a couple clips where people will joke about it, and there's about being food allergic.
The media can do so much better. When they don't make it clear that food allergy is just as serious and just as potentially deadly as a heart attack or a stroke, they basically are encouraging the public not to take this seriously.
Sometimes there are folks who say something that's hurtful.
Maybe if touching a nut kills you, you're supposed to die.
Hey, 2 to 5 minutes, that peanut in the joke, this child could be dead. That's not funny.
When we make a finding, the media has to be very careful about how they present it. It doesn't mean we've cured food allergy, and oftentimes that's the way it comes across.
So you'll see the food allergy tragedies in the media. They don't highlight the fact that these reactions and these tragedies are 100% preventable. The media doesn't focus on what we're doing about the tragedies. They just, there was a tragedy.
When people do make mistakes in the media, we need to help them, get them educated, make sure that that mistake doesn't happen again.
Our major goal is to educate the population about why food allergy is a serious disease and why we need therapies and accommodations for people.
Food allergies can be fatal. What's funny about that? Nothing.
All right. So, a little harsh, but so we've talked about avoidance and avoidance measures. Now we're on to the second part of management, which is the treatment of symptoms. So a critical and often overlooked, maybe in practice, part of treatment of symptoms is the development of an emergency care plan. This prepares patients and their families and other caregivers how to provide swift and appropriate treatment in the event of an allergic reaction. And I'll show you one on the next slide. And then there's the most important part of treating a severe allergic reaction, which is the prompt administration of epinephrine, usually in epinephrine auto-injectors. The earlier the administration, the better, because it becomes less effective the later it's given after its symptom onset. And then just to kind of highlight how important it is to not delay treatment, in 2017 there was legislation passed in New York which gave school bus drivers and the right, I guess, to administer epinephrine auto-injectors to children in emergency situations. So this is something that is, on the forefront of people's minds. There's 2 doses to remember for epinephrine auto-injectors. There's the 0.15 milligrams, which is for kids 15 to 30 kilos, and then there's the 0.3 milligrams, which is for kids 30 or more. While it's the most important and should be the first treatment given to anyone with any food allergy reaction, antihistamines can sometimes have a secondary role after the administration of epinephrine. And then in patients with concomitant asthma especially, or those with wheezing or respiratory symptoms, bronchodilators can also be used as a secondary treatment. So then kind of another Anthony story that I have. He is pretty good about bringing his EpiPen with him. But one time he left with his EpiPen, and then luckily he didn't need it, because when he came back he realized that he had brought the epinephrine trainer pen, so not the actual pen. And he's like, oh, well, good thing, But just sort of keep in mind that as experienced as you are, you still need to sort of make sure that you're hyper-aware and hyper-vigilant, and that the epinephrine auto-injectors that actually contain the medication would probably be more beneficial in an emergency situation. And then here's just an example of our emergency care plan. I got this from FAIR. If you look at it, it's not completely unlike the asthma action plans that we provide for our patients. So is there a third part to management of food allergies? Maybe prevention. We're not really sure what causes food allergies or how to prevent them on a larger scale, but there is the one study was highly publicized, the LEAP trial, or the Learning Early About Peanut trial, which was published in 2015. It was a 10-year study, and it indicated that avoiding peanuts in the first year of life actually increased the risk of developing a peanut allergy. And this study in particular is important because AAP recommendations in the year 2000 had actually suggested that patients who are at a high risk of developing peanut allergy avoid peanuts for the first 3 years of life. And after some evidence surfaced that didn't show any benefit to avoidance, in 2008, the AAP rescinded the recommendations but didn't replace them until 2017. So the newest recommendations from last year recommend that for highest risk infants, which would be those with severe eczema and or an egg allergy, peanuts should be introduced at 4 to 6 months of age after the successful introduction of other solids. And then also worth noting that it is highly recommended that these kids get allergy tested before you introduce the peanuts. That could be either skin prick testing or IgE, although skin prick is preferred. Although if their eczema is severe, they probably won't be able to get skin prick testing. It's also recommended that they are monitored either very closely at home or in the office by a physician. And the dose is like 6 to 7 grams total over the course of 3 feedings per week. And then for kids with mild to moderate eczema, the recommendation is to introduce peanuts at 6 months if once they've introduced successfully other solid foods. And this can be at home. There's no requirement for prior allergy testing or physician surveillance. And then for patients with minimal risk, which would be those that don't have eczema or any other food allergies, they can just introduce peanuts freely in their diet whenever they want. So I really wanted to talk about today the psychosocial impact of food allergies. A food allergy diagnosis can be and usually is a life-changing diagnosis for the patient and for their family. And it can result in parental stress, parental and patient anxiety, and bullying. And then I just wanted to kind of put another video that's from FAIR that can help us to kind of get in the mindset of a parent of a child with food allergy. It'll work.
I think about my son's safety every second of every day. It is my top priority, and I think a lot of parents don't understand how vigilant you have to be. Having a son with food allergies adds a level of stress and anxiety. When he first got diagnosed, it just rocked my world. In addition to being a new mom, I now had the stress of dealing with a world that has food everywhere.
Ben is allergic to peanuts, tree nuts, eggs, beef, fish, coconut, chickpeas, seeds, and mustard. It's not something that just causes sniffles or maybe a couple hives. This is a life-threatening condition. Grocery shopping takes about 2 to 3 hours. You have to go through every aisle and look at the labels. Each time you go, I actually have 3 supermarkets that I go to because each of them has some of the food that I can buy. Food allergies make the world a minefield. Everywhere my son goes, there's a chance that he could be poisoned by everyday food. We had an episode where Ben ate a piece of taffy. He had a tiny nibble of the top and went into full anaphylaxis. Immediately, his tongue started to swell. He broke out in some hives. So we found the nearest emergency room and took it from there. Ben's school has been phenomenal with his food allergies. We're very lucky in that respect. He has a 504 plan that covers the way that the food allergies can impact his learning. And he also has an individual health plan. And the school health aide keeps an eye on Ben, and she's aware of how severe his allergy is. My worst fear is that I will not be with Ben when he has an allergic reaction. Every moment of the day, even if he's at school, it's something that's on my mind. I think people need to understand that food allergies are ever present. This isn't just a phase Ben's going through. His doctors are pretty certain that this is something he's going to have for the rest of his life. And so he's had to learn to deal with it as a child. He'll have to learn to deal with the challenges of having food allergies as a teenager and then as an adult.
Food allergies are serious and life-altering. To learn more about food allergies and
So I feel like that video kind of segues really nicely into the next section, which I'll discuss how exactly it impacts at different ages. So in the psychosocial impact of food allergies varies with the different age groups. In early childhood, the parents are pretty much solely responsible for appropriately managing their kids' food allergies. Especially in the first year after diagnosis, a lot of parents report, most parents report, that they limit the activities that the children are allowed to attend outside of the home. Most indicated that that they avoid restaurants altogether, so no more going out to eat as a family, no more celebrations out. And then about half said that they restrict social activities and or travel. So this really affects quality of life and can sometimes lead to some mild social isolation. It's also been documented pretty well that the kids with food allergies have a higher rate of separation anxiety compared to their peers. Now, whether this is an appropriate response to having a life-threatening condition, hasn't been studied. So when kids with food allergies begin school, the parents are kind of forced to relinquish some of that responsibility of managing the food allergies to others. So the teachers in the schools will accept some of the responsibility, but really the kids themselves also have to accept the responsibility for managing it appropriately. Because kids are leaving their safe home where they know what's safe, they know what's not going to harm them, a lot experience an increased level of anxiety that can be pretty severe. There were many that had reported an increased fear of death out of proportion to the severity of their allergy, and not correlating at all with the actual objective probability of death. And then, as with any chronic illness, really, children with food allergies are at a greater risk of being bullied than their peers. So this was, when I was reading up on this was surprising to me that in a study I found from 2013 by Shemesh, it had about 31.5% of adolescents with food allergy reporting being bullied, kids with food allergies reported being bullied specifically for their food allergies, and 80% were their classmates, so they're kind of trapped with them during the day. The bullying ranged from, the fairly mild verbal taunting to being threatened with their allergen, and even some had responded saying that they were forced to physically touch their allergen. I mean, that's just like assault. And then bullying, which is no surprise, was associated with a poor quality of life independent of the patient's allergy severity. There was, only a 50% rate of parents being aware that the bullying was going on. Parents' awareness was associated with an increased quality of life and a decrease in the levels of distress that patients with food allergies felt about their bullying. And then, according to FAIR, children with food allergies are twice as likely to be bullied as kids without medical conditions. So, in adolescence, the responsibility of managing the food allergies is now being completely transferred over to the patient. So there's an increased risk of severe reaction in this age group, secondary to non-adherence, but also to risk-taking behavior. And 67% of adolescents and young adults had reported a reaction in the past 5 years. And most fatal reactions, most fatal food allergy reactions happen in adolescents and young adults, usually while they're away from home, whether it be at college or just out. And it's no surprise to us. I mean, adolescents often partake in risk-taking behavior in many aspects of their life, so adolescents with food allergies are no exception. A small study of 18 teenagers with food allergies that was published in 2010 indicated that teenagers with food allergies exhibit several risk-taking behaviors, including consuming foods that have the allergen listed under the may contain warning, and only carrying their EpiPen or epinephrine autoinjector when they felt they were at especially high risk. And then another study, if for kids in the United States between 13 and 21 with food allergy, 50% had knowingly eaten their allergens, and many admitted to trying a small amount of an unfamiliar food, kind of waiting a little bit to see if they reacted, and then if they didn't, just going on and continuing to eat the food. So this is my last Anthony story, I promise, but speaking of like risk-taking behavior, he, a couple years ago, was invited over to his friend's house for a Hanukkah dinner, and he's a polite kid to a fault. He gave his list of his allergens to the mom, and I don't know if it was cross-contamination or something, but he noticed like immediately upon starting to eat the casserole that something wasn't right. He was having a reaction. So instead of politely, saying, hey, I think I'm having a reaction, he didn't want to seem rude, so he finished his plate. And then when she offered him seconds, he politely accepted. So that's kind of an example of what not to do. It's not worth it. We should be making sure that our patients feel like they have the ability to speak up for themselves. But in addition to this risk-taking behavior, adolescents and young adults with food allergies are discovered also to not adequately use their epinephrine. So in a 2013 paper, only 13% of college kids that were surveyed that had a previous history of anaphylaxis carried their epinephrine autoinjectors with them. And they had several reasons, like maybe they didn't have a bag or a backpack that went with their outfit or with the activity they were doing, or they were wearing tight clothes, it would be difficult for them to conceal it. Another study documented 83% of teenagers who had reported anaphylaxis in the previous year didn't use their epinephrine autoinjector when they were having anaphylaxis. And then also another study showed that a lot of patients who have severe reactions like dyspnea or loss of consciousness and angioedema of the mouth didn't even realize that these were severe reactions that could constitute anaphylaxis and use of their epinephrine autoinjector. Kind of what's our job as pediatricians? Well, according to the Critical Issues in Food Allergy National Academics Consensus Report that was published in Pediatrics in 2017, pediatricians should be counseling regarding avoidance of allergens at home, school, and other locations like traveling, the need for careful nutritional monitoring, but also we should be paying attention to the psychosocial aspects of food allergy. Particularly bullying, the risk of bullying. We should be screening for bullying in our kids with food allergies, and we should be helping to provide patients and their parents with the resources to appropriately equip them to navigate these situations. We should also be advocates for increased awareness and education on food allergies and strive to help dispel or eliminate any misconceptions. And we should just always be continuing to educate on appropriate treatment to our patients and our families of their symptoms, particularly like the when and how to use an epinephrine autoinjector. And then I just have a couple of tables that I thought were interesting. I didn't want to just copy and, but you can go ahead and read those. This is a table that I found from a paper called Clinical Management of Psychosocial Concerns Related to Food Allergies, which was published in 2016 in the Journal of Allergy and Clinical Immunology in Practice. And it shows common questions that regarding food allergy that providers should be prepared to answer from their parents and their families. And it's kind of separated out into those different groups. And you can kind of see from where I focused during the different age groups, what the concerns are in the different groups. So in early childhood, the question is, how do I teach them about it in a developmentally appropriate way? How do I keep them safe by explaining to other caregivers and making sure that they're taking it seriously? For school-age children, how do I help them cope with anxiety? How do I help them if they're being bullied in school? And adolescents, how do I transition care to them? How do I impress the seriousness of the allergy and help them kind of disclose to peers and navigate peer situations? And then to sort of finish it up, I have another table, which I thought was pretty relevant to us, from the same paper that lists questions that we as providers should be incorporating into our practice to ask our patients with food allergies to help assess their psychosocial functioning. So it's important to screen patients with food allergies and their parents for the psychosocial impacts that they might be having on their lives. And an important component of the screening is also to ask how frequently their concerns are affecting their daily life and how long that they've been having those concerns. An increased frequency or duration of concerns might be an indication to refer to a mental health provider who can provide cognitive behavioral therapy to patients and their families, which, if there's no underlying diagnosable mental health condition, is usually a short-term treatment that's goal-driven. And then there's also been evidence that shows that one of the most beneficial interventions for families who are impacted by food allergies is, development of a social support group. So like a parent, directing parents to support groups, directing kids to maybe special camps or weekends where they can feel like validated in their concerns and the many ways that it's impacting them from a psychosocial perspective. So, you can see kind of, it's separated out into the different topics. I thought interesting things to note. Does the kid ever not want to participate in social activities because of their food allergies? Are they ever left out or teased because of their food allergies? And then just a lot of testing about how worried parents and kids are about their allergy, and then also how is it affecting what they're choosing to do. So I think as physicians, we tend to focus, or it's easy to focus on the pathological or the medical, the solely medical management of any condition. But my hope is that we can do better to take a more holistic approach to our patients with food allergies. We do it in other chronic illnesses. We address the psychosocial impacts that it has on their life. But I think we can do better for kids with food allergies and their parents and not neglect the very real psychosocial impact that this diagnosis has on their everyday life. So I hope that this presentation was informative and maybe provided you with some allergen-free food for thought. I don't know. Any questions? Anyone? Yes.
That was a great presentation. I just had a question.
Mm-hmm.
I know the CT contrast and shellfish allergy myth has been largely debunked.
Mm-hmm.
Are there any medical considerations with food allergies that can impact a patient's care?
What do you mean?
I mean, would you not give any medicine if a patient has, say, a severe milk allergy? Are there any cross reactions to worry about?
So I didn't really go into that when I was looking it up. There are with vaccines and stuff. So like egg and yellow fever vaccine, I believe it is, and then gelatin and MMR. But I don't know. Probably.
Dry powder inhalers usually have lactose and can have milk protein contamination, so that's a concern.
Which one?
Dry powder inhalers, so the ones that are blister packs and capsule that you drop in a twist, so also for MDIs, ipratropium and peanuts can cross-react. So ipratropium is sometimes a concern. Propofol, again, egg issue, it's the less tendencies to make an emulsion. Those are kind of the ones that I think of when I try to, which is why it's important as we are taking allergy histories in our electronic system or asking versus taking allergy histories, that we're not just cold typing in words. Sometimes the allergen search, if you actually do that allergen search, it will help ensure that those are actually flagging electronically as those orders are entered, as opposed to kind of, oh, I didn't find shrimp, so I just typed in, seafood, so it doesn't, so if you actually, if it's coded, hard-coded, those actually do, as new products come on the market, help us keep those in mind. So I try to always remind nurses if I see one that's just been kind of typed in as a free text as opposed to coded, that we try to go back and I can code them on my side if you're ever having trouble. If you hear someone having trouble coding allergies, I can actually code them. If you're having trouble, I can usually code them in. But you should be able to, on yourself, as you're doing all these, actually code those, not just free text them into those allergy fields. And that does help.
I have a question. You mentioned that some of these food allergies you outgrow. Is there kind of recommendations you are out there for when you should be retesting kids for allergies? And is there any kind of psychosocial awareness that we should have? Parents who've been told their kid may die in one moment if they touch a certain allergen, but here, let's go ahead and reintroduce it and see how they did it.
Yeah, I mean, that is a big thing. That was actually one of the questions that was on that was, about the anxiety about an oral food challenge. Sometimes allergists will look at IgE serum levels and then see, like after the median age when kids will grow out of it, see if there's still a high level of antibody, if it's still considered a positive test, which might just mean that they haven't consumed it, in a long time, which probably. But then they might then try to go to an oral food challenge, in which they would monitor for any reaction. So it's kind of the same thing. You just kind of go through the diagnostic steps again. A second time around, I didn't actually look up what the recommendations are for the ages, but I imagine probably after 5.5, 6 years, especially if they've done a really good job of eliminating that from their diet. But that is a big problem. Patients and their families are like, no, I don't, even if I find out that they're not allergic, they had anaphylaxis with it. I'm not going to feed it to them. I'm not going to even try that. So it is a kind of a huge psychosocial thing. Yeah. Yes.
I have a couple of comments, Mary. Thank you for a really illuminating and informative talk. I love what you had put up from that FAIR website, and I really like the allergy action plan. I would love it if you could print lots of copies and help us incorporate it into part of our regular process whenever we see a kid with allergy in our clinic, whether that be that the nurse ends up filling it out or starts to leave it in the door for the doctor to address it and fill it out. I think that would be a great first start in providers addressing allergies. So I would love to see if we can start incorporating that. My second comment is what you mentioned about teenagers, adolescents, young adults, and how they kind of fall behind. It's hard to carry the EpiPen and it really is kind of cumbersome. If you look at how it's made and what it looks like, it really is pretty cumbersome to carry it. To the point, my husband has a shrimp shellfish allergy. I actually have an EpiPen in my purse. I carry it because he never carries it in his purse. He's never able to carry it, and I hope that if we were somewhere where there may be cross-contamination, that I'm the one eating with him, that I'd have the EpiPen. But all the time? No. So, I mean, that's my point, is that it is hard to carry. No, he has one in his drawer at work. I have one in my purse, but my point is it is hard to carry. And so as we go further into this, I think looking at creative ways in which it's a usable EpiPen, I think that would be very, very useful I know you're headed into an allergy immunology career, so we would love to hear a few years down the road, Dr. Kearns has made a really usable EpiPen. But the third point being that I think there's a lot of work to be done with legislation in the school system, because some of the things that you read about, it talks of the unfortunate death of a child who didn't have an EpiPen to their name, but the school actually had epinephrine in some other child's name,
Right.
but didn't use it because of legislation and because
They
of
can't.
how the laws are written. And so I think trying to move it at a legislative level for whoever may have an interest in it, that is actually something that's, I think, a very important piece, that if you have epinephrine, you suspect a kid has an allergy,
Yeah.
even if it is not written in their name, please use it for the child so you can save their life.
Yeah, especially since like the majority of first reactions occur in school, and then there's 3% every year of anaphylaxis that happens in school. So school is a very important place for food allergy management.
So I think as providers, we really need to advocate more of the 504 plan, co-opting with the schools, having them understand what really is entailed in the allergy piece.
Yeah, I wholeheartedly agree. Anyone else? Okay, great, thanks. Well, just my resources. They all got messed up, I don't know how.